as we celebrate the as we celebrate the World Food Day. Actually, the World Food Day was yesterday. It is celebrated on the occasion of the founding day of the Food and Agriculture Organization of the United Nations. Every year, a theme is given. This year's theme is Leave No One Behind. As you know, despite all the measures that different countries are taking, there are several undernourished or malnourished to that to be precise, both undernourished and overnourished, and people who are susceptible to overweight, obesity, and non-communicable diseases all around the world. And these have been exacerbated by different kinds of issues, including unrest, civil unrest, social and economic stigmatization, as well as migration and illiteracy and low incomes and many other issues. So the theme aptly covers and suggests that post COVID-19 or in the post pandemic era that we are in, we have to actually make good for a lot of losses and other things that have happened during the pandemic. So this is a situation that the world is confronting, including wars and unrest around the world. So in this situation, today's topic actually deals with how to bring everyone in the ambit of ensuring food and nutrition security. So there are large groups of vulnerable population, as you all know. The 7 groups of vulnerable population that we usually discuss are women, children, pregnant women, lactating women, adolescents, elderly, and others. But the large section which is missed out are the migrant labor, street children, elderly, destitute who do not have their loved ones to take care of, and many other things. So in that endeavor, this webinar today tries to cover 2 or 3 important groups which are usually left behind in the safety net programs. That is street children and also elderly, for whom there is a requirement for specific nutrient requirements to be brought out. So this webinar is being organized in that light. And I thank our director, Dr. Hemlata, who's unfortunately not being able to join us today because she had to travel to Delhi, for actually giving us the idea of getting someone to speak about street children and the elderly, and that's how we moved forward in this respect. Now I welcome Dr. Uday Kumar to deliver his opening remarks. Before that, I will request my colleague Kiran Mai, who is a project scientist B, to introduce Dr. Uday Kumar to us.
Good morning to one and all. I'm happy to introduce Dr. Uday Kumar, who's a scientist G and head of pathology and microbiology division. His areas of research interests are nutrition and cancer interaction and nutrition and toxicology, fluorosis, food allergy related, knowledge, attitude, practices, among others. He has published widely. He is a CPC SEA nominee under Ministry of Animal Husbandry, Government of India, and inspector for various government organizations and industry. He is also a trained GLP assessor working on behalf of National GLP Monitoring Authority of DST, Government of India. He is a life member of Indian Association of Pathologists and Microbiologists, Nutrition Society of India, Society of Toxicological Pathologists of India, Laboratory Animal Scientists Association, and member Indian Medical Association. He is on the teaching faculty of courses in nutrition as well as laboratory animal sciences. He will be delivering opening remarks and welcome address on behalf of Director.
So please unmute yourself.
Sorry. So thank you very much, Kiran Mai, for the introduction, and thank you, Dr. Subbarao. So good morning to all of you, all the scientists, academia, students, PhD scholars, and all those who have joined this seminar, and Dr. Antaryami Das, Dr. Shekhar, and Dr. Bhan Prakash Reddy, who are the speakers today. Last but not the least, Dr. Subbarao, who is the coordinator for the whole thing. Yeah, so on behalf of NIN, I welcome all of you. On behalf of the director, NIN and my own, I welcome you on the World Food Day celebrations being conducted by ICMR NIN through this webinar titled Leave No One Behind, the theme that was coined by FAO for 2022. On this background, it is important to realize that the World Food Day is our day. It is not that it's only the organization FAO that is supposed to do it. Everybody should feel responsible of that. And it happens to be one of the most celebrated events by UN and FAO across 150 countries, the World Food Day, on October 16th. As part of the inaugural address, I wish to share a few ideas and thoughts on the topic of Leave No One Behind. Let me start by saying that in every sphere of life, it is possible that for a given task, not all aspects would be completely covered, and inadvertently, a few activities or modalities may be left or missed out due to possible oversight. In this context, the present theme of FAO, Leave No One Behind, is an apt indicator or a pointer to delve deep into the issue on hand, that is, good nutrition and health for all, and leave no one behind. As such, may I state that there are multiple vulnerable groups in the population as per epidemiological or demographic distribution, which would also include the very, very young and the very old populations, in addition to other known vulnerable groups like pregnant women, etc. A new dimension that got added due to the recent COVID-19 pandemic, in addition to the already prevalent vulnerable groups, are the migrants and the destitutes. The nutrition needs of the population would involve not only quantity but also quality of the food that is available, which should be accessible and affordable. Not only hunger has to be taken care of, which is being done through various schemes of the central government and the state government, but the nutrient content, that is the quality of the food supplied, also needs to be looked into for optimal health to be achieved. As per FAO estimates, there is enough food for everybody on the planet. However, geoclimatic, geopolitical and geoeconomical factors play a major role impeding the supply of food to all sections of the society and all types of populations. That's a tragedy. However, the major causes for food insecurity and undernutrition are poverty, inequality, climate extremes, conflicts, economic mishaps, etc., leading to non-accessibility or non-availability of food. On this background, I see that the present symposium or the present webinar that is being conducted today is dealing with the issues of two most vulnerable groups. One is the elderly and the other is street children, which are rarely covered in nutrition safety programs like your midday meal scheme or your public distribution systems, etc. They are being enumerated by speakers, Dr. Antaryami Das, who will speak on street children, Dr. Shekhar on elderly population, and Dr. Bhanuprakash Reddy, who will actually emphasize on why we need special nutrient requirements for the elderly group specifically. Wishing all the best for successful deliberations that will take place and which will give us good take-home messages at the end of the webinar. All the best and thank you.
Thank you, sir. Before we go ahead with the talks in the webinar, I have a few administrative and housekeeping announcements to make. All the attendees are free to post their questions in the Q&A box or in the chat box. Each presentation will last for about 25 to 30 minutes, followed by a quick round of 2 to 5 minutes of discussion, depending on the questions that we get. And if we are left with more time, probably for all the three presentations, we'll take questions at the end also. I hope the instructions are clear. Once again, a request for all the panelists to keep their mics muted, except for the speaker. Just in case there are any questions for the panelists to ask directly, they will be allowed at the end of the presentation on a raised hand option. Thank you so much. I hope the instructions are clear. I'll now invite my colleague, Dr. Bhaskar Reddy, who has joined us Scientist B recently in our division, to please introduce our next guest.
Thank you, sir. Good morning to all. I'm happy to introduce Dr. Antaryami Das, today's our guest speaker. Dr. Antaryami Das is the Deputy Director of Health and Nutrition in Save the Children India. He is a trained public health and nutrition professional with over 15 years of experience in program management and designing programs and ensuring their quality implementation, harvesting its outcomes to influence of policies. Is having worked with UNICEF and government system in the past, he provides the thought leadership and technical guidance and knowledge management support to strengthen program delivery at large scale. And with this introduction, today is going to talk on street children and safety net programs, current scenarios and challenges. Thank you, sir.
Dr. Das, can you please share your presentation? Yeah.
Thank you. You can see my screen.
Yes, sir. Can you put it in the slideshow mode, please?
Is it okay?
Yes, it's okay.
Okay. So, good morning, everyone, and thank you, Dr. Subbarao, for inviting me to this very important discussion. As as you all know, that street children is a most vulnerable, and although they you find them in every street, in every railway station, but it is still a very difficult a catchment population that is devoid of so many programs that we talk about. So their vulnerability is nothing comparable to any other children or any other target group in the country, and their numbers are also appalling. So let me start the presentation with a very small 2 minutes video to make you understand about their vulnerability in the street. Just a second. Sorry, some problem. In that case, I will just show you from here. It's loading. I'm really sorry about the glitches. I think it should start.
Sir, can you turn on the audio, please?
Yeah. Sorry, I think it will not happen that way. Just a second.
You can try from VLC player if you have.
Let me 1 second try here. Not a problem. So I will try it later.
Okay.
Let's go to the slide. So who are these street children, and their definitions is very complex again. And you can see that as per their vulnerability, you can classify a street child on 3 different ways. First is a street child who is run away from their home and their families, and they live alone in the street. They are highly vulnerable because they are not staying with their family and they don't have a home to stay. So they are literally staying on the street. The second category is the children who they're loitering around the street all day, but they have a home to go back and stay in the night. They are relatively less vulnerable than the first category. And the third category of children are children on street, but they're also living with their families in the same town, in the same city. So if you look at as per the vulnerability, the first definition, the first category of children are most vulnerable because they are staying alone and they don't have a house to stay. They're literally staying on the street. So they're most of them are underprivileged and vulnerable, with very limited access to protection, education, healthcare, nutrition, and even adult supervision for them. Now, there are more than 100 million street children around the globe. In India, we don't have a very realistic estimate how many are there. There are different studies, different estimates, because census is not capturing them. So different estimates says that they are probably around 18 million across the country. And I will show you some data of our own programming across 10 cities over 4 states. It's very difficult to plan a comprehensive action plan for them because we don't have a reliable estimate, because we cannot count them. That's why we cannot plan for them. And as I said, national surveys and census are not adequately capturing their number. And the reach of different welfare schemes and government programs, it's very limited coverage for them. You must have seen similar kind of a situation in every major railway station. If I may ask, why do you think that most of these children in street are found to be loitering around, moving around, and staying and spending most of their day in a railway station? Any guess? There are children who probably you may find they are spending the maximum time in the street, in the traffic, or somewhere else, but they will find comfortable to go back to railway station in the night also. That is also there. And in our studies, we found that this study that I'm talking about, we did it in 10 cities, and out of the 10 city, Mughal Sarai is also a city, and we found that majority of the children are found in the in the station. And the typical timing to find them in the station, especially in Mughal Sarai, is 12 midnight. That's the time when 5 of the Rajdhani Express they go and they transact with another 5 Rajdhani Express. They come back. So this is a intersection point. And do you know why are they there? Because of food. And Rajdhani Express are probably is the only express that has a very good pantry car, and they provide food. So during this time they throw or they distribute some of the food that they are not been able to use for the day, and they find it there. They also prefer railway station because it provides some kind of shelter to stay, a shelter to sleep. There are hospital facilities, there are first aid, and sometimes you will find some police officers are also roaming around in the station. So some kind of perceived safety that they find in this station, and of course that gives them the next destination. So that is how they are there. But it also brings additional vulnerability, life risk, and threat to the children because of different hazardous activities that they are indulged into. You can see these photographs, and they very much explain the situation. They don't have identity. In our programs, we found that they don't have Aadhaar card, they don't have birth certificate, they don't have anything. And because of lack of such identity, they cannot access formal education. They are forced to do child labor. They cannot access any government welfare schemes or health services or any kind of legal protection. So everything is rooted through their identity. If they don't have identity, then it becomes a whole lot of difficulty to access all these social protection schemes. There are different kind of health and nutrition, and for today's talk, I will be more specific to hunger and nutrition, food security. It's very important for them. If you look at the food insecurity and hunger, that becomes the cause of a child to run away from the households, because there was food insecurity at the household in the first place. We have done so many exit interviews of children who have run away from their households. One of the top 3 causes for them to leave their house and come here is a acute food insecurity and hunger. So that is, of course, there are many other causes, but that is also a major cause. And after coming here, they still suffer from hunger and food insecurity, and I will be showing the data around that. So it's not that they fled their house because of food insecurity, and now they are having a proper meal. That's also not the case. So during the runaway stays, during the transit, and being in street, in all 3 places, they are actually suffering from food insecurity or nutrition insecurity. Their access to basic health services, basic thing such as immunization or any other thing is hugely compromised, and they cannot access it. Nobody is screening their anthropometry. Unfortunately, we have now around 1200 NRC across the country. Every rural village, there is a program for their screening of malnutrition. If they find that the child is very vulnerable, malnourished, there is a mechanism to send them to NRC, but nobody does that for these 18 million children, those who are in street. And it's not that they are not malnourished. If you look at their anthropometry, there are different studies being conducted across major metropolitan cities. They are found to be highly malnourished, but they are not accessing any of the social safety net programs like ICDS, like MDM. There are many communicable diseases which are very prevalent in them. I am not reading out. You can very well understand that since they don't have access to health services and they are staying in a unhygienic atmosphere, so obviously there are so many problems that they will undergo. Mental health is a big issue because they are socially isolated. They have no adult supervision. They have no one to talk and console to. So that is another issue. Substance abuse, and by the way, we found that the cause for which they do substance abuse is to reduce the hunger. So they take different kind of substance abuse. You and me, we cannot imagine the Fevicol, the glue. It has a chemical, and that gives some kind of addictive thing, and that probably reduce their hunger, so they don't feel hungry for the day if they consume that. So that is how they're using. There are cases of injury, traumas to such children because they are exposed to constantly risky activities. It can be a traffic signal. They will be moving around, dancing, and showing you different tricks to appease you, or it can be a railway station. They will be exposed to such accidental hazards. Exploitation, abuse, sexual abuse, these are very common in these children. So their problems are not limited to only food, nutrition, or health. It's cutting across all the major social evils that we are talking about. The study that we did in 10 urban cities in 2016, These are across 4 states, and the cities are Nasik, Pune, Mumbai, Kolkata, Mughalsarai, as I said, Allahabad, Lucknow, Kanpur, Agra, Delhi. We find that the category of children that we talked about, 59 or 60% of these children are on the street. Only 37% are staying with their families, and only a minuscule 3% they are living on the street. 3% on the street, and 60% are doing some kind of activities on the street, and they earn money. The money that they earn, it's very interesting. How do they spend that money? Let me go back to that slide first. Yeah, how do they spend that money on different activities? You will see the food expenditure is the majority. The 71% of children on the street, they say that they're spending this money that they're earning is on food. Others say that even if there is some surplus money, they cannot save it because they don't have bank account, they don't have a purse, they cannot keep it everywhere. Any surplus amount that they save after spending on food is being snatched away by the elderly children and sometimes other people. So it's better to spend it on food. And what kind of food do they buy? Do you think it's a balanced, healthy diet they're purchasing? It's 90% it's a junk food, right? So nowadays in urban area, in different settlements, you will find cheaper food options which are junk food. Sometimes these healthy food are more expensive for them, and it's true for everyone. The cost of diet that we did in Jharkhand, it says that the cost of a healthy, nutritious diet is 2.5 times more expensive than a calorie-only diet. So that's the only source for them to resort to, to live, to survive. And you can see the other expenditure as well. I'm coming back this slide. Now, how many times in a day they are eating on different kind of children? Just mark this last column. There are children who spend the whole day and night without having a meal. And of course, there are children who only have a single meal in a day. There are children who have twice a meal a day, thrice a meal a day. But there are children who go to sleep hungry the entire day. Their number is not less. If you look at this, 6 to 8% of 18 million children in the country, you will find the precarious the hunger, the situation, you can understand. Okay, so about the awareness and the assistance they sought, we found that 60% of children are not aware of any support system or any kind of assistance. So simply they are not aware of anything. Only 7% of them are aware of a specific support system. 78% of children never approached anyone for any assistance, and assistance of food was received by only 11% of children. So lack of awareness, lack of understanding about the social safety nets, about different support system available. So even if they are aware, they are hesitant to seek such supports, because for that you need to know the channel, and you need to know how to access it. So it's very much negligible for them. There are now provisions for these street children, ICPS, then ward level child protection committee under Mission Vatsalya scheme. Then NCPCR is the nodal agency which is talking about the rights of the children. RTE, literally it talks about nobody should be devoid of education even if they are children in street. POSCO, JJ Act, all these are there. But having all these schemes in place, the reality is that 60% of them are not aware about it. Hardly 8 to 10% are accessing such rights. There was a program for 2 years. Save the Children supported a program, Surviving the Streets in India, and it was across 10 cities in 4 states, and we provided identity to 2.8 lakhs children. So we have given them their voter ID, sorry, the Aadhaar card, the birth certificate, and different kind of legal entity and papers. Thereby, they got enrolled to Anganwadi centers, schools, and they can access health services from various government and public facility. And we linked out of this 2.8 lakh, we linked 1.4 lakh of them with various government social protection schemes. And to our pleasure, we rehabilitated close to 2,000 such children back with their families. And we supported 3 transit homes, 2 in Delhi and 1 in Uttar Pradesh, to become a model center to accommodate such children, to engage them in play, in learning, and in different kind of life skills. So these centers are still there, and now they are being handed over to government. So these are some of the schemes that we supported, and this is the way we provided critical social safety net supports to these vulnerable children. In another program that was for the 5 cities, and we found that 50,000 such children were found from Hyderabad itself, and similar kind of support being provided to them. There is a multi-activity center that we run in multiple cities. So these multi-activity centers are providing all kind of life skill, health, education support to children those are in street. So this is about the issue and the challenges, and some of the programs that we have supported. I'll be happy to take any questions. Thank you.
Thank you, Dr. Dash, for that lucid and clear presentation. There is a question in the box. The question is about what was the age group of children? Were the parents interviewed? Who answered for them? Did the children themselves answer? Because I'm sure, parents wouldn't have answered because they are street children. And
right.
Why this question is asked is whether how easy or difficult it is to get the children to answer the questions, because very difficult to catch hold of them. Can you just elaborate on this?
Right. So there are 2 types of children. Literally, if you say the child definition, it can goes from 0 to 19. But children who are coming to street are always above 6 years, because they cannot come before that. So we find them typically 6 years onwards, and the median age that we find is around 13. So most of them in the range of 6 to 19, or sometimes 8 to 19 they come. And the survey that we do is very simple questions that can be answered by a 10-year or a 11 or a 13-year child. So this is not very complicated. And for those 2,000 children, we rehabilitated them with their families. So at that point we interviewed the family member. And as I said, there are some 30% children, those who are staying, with their families, in the cities. So that is another category. Those, questions can be answered by the, caregiver or the family member. So our, sample size was very close to, 2 lakh in these 10 cities. So it provided a very huge stratification of children based on age, based on their, categories, staying with family, without family. So it has a huge this thing. Thank you.
Thank you. It's a revelation that the street children do stay with their families, because the general perception is that they are the ones who run away from the family usually. And thank you very much. And one question is about the Surviving the Streets in India program that you ran. And you also said in another slide that children are aware of certain programs like the ICPS and Mission Vatsalya and things like that. What is that differentiates those children who know about the programs and their rights, and the children who do not know? Is it a little bit of education, or how do they get to know about these programs?
So there are different kind of programs, different government agencies and NGO partners are doing in the street, and there are special drive that we conduct. If you come to Delhi, you will find there are very good initiatives been taken in Delhi, and there are begging free zone being identified, and there are different kind of awareness drive being conducted. So it's not that nobody is taking any initiative to teach them or to aware them. There is a lot that is happening, but still majority are not aware about such things, and such intensive drive and awareness camps should happen on a day-to-day basis. The biggest challenge is that we don't know how many are there, so a census has to happen for them. And typically the I don't know, there are professors from IIPS, and they can comment. I think the homeless population that we capture, the child is up to 0 to 6, and beyond that we don't have that technical indicator how to do that. It's also challenging how to capture them, because there are some questions that you ask. Is this person slept in the same house in the previous night? There are complicated survey questionnaire that doesn't hold true for such children, because they don't have a fixed house to stay or to sleep in the previous night. So I don't know how to deal with that situation from a enumeration perspective. But the challenge still remains is that they are uncounted, they are unidentified. That's why their vulnerability is just the tip of the iceberg that I presented. That we don't know what is happening with them at a deeper level.
Thank you, sir. One last question, and then the question is pretty long from one of our PhD scholars, but I'll just make it quick. With the lack of identity documents among bottom strata of society, including the street children, the targeted PDS with multiple bottlenecks, is it a viable system towards ensuring food security, especially if we aim to leave no one behind? Or should we just aim to universalize the system of keeping these kids and bringing them back home?
Yeah, it's a very good question, and it has a macroeconomic and a very social inclusive angle. If you look at any kind of targeted programs, has this inherent challenge of excluding some people, because you are targeting basis some criteria, and the moment you fix these inclusive inclusion criteria, there will be loopholes, there will be problem. The biggest problem that I just explained is children in street, because how do you identify? After identification only you can put some inclusion. So if you cannot identify, you cannot include. So that's why the universalization of any scheme will automatically capture anybody who you find in street or in home, in community, because you don't have to count them, you don't have to put any inclusion exclusion criteria. You just saw, you just cover it. So that is that has this advantage. But budgetary provision and everything, you have to weigh that how much extra cost you have to bear because of the universalization. And universalization will also minimize some of the admin cost. Right. So there are debates around PDS target and targeted PDS and universalization. I don't want to go into that debate now, but yes, it's a valid question and a very valid point to ponder upon for such children who lose through the mess, and we cannot capture them through any kind of criteria.
Thank you, Dr. Dash, for patiently answering those questions. Well, in time, we'll move to the next presentation by Professor Shekhar. But before Professor Shekhar starts his presentation, I would like my colleague, Ms. Paramita, to please introduce the guest to all of us.
Good morning, everyone. I'm glad to introduce today's speaker, Professor T.V. Shekhar. Dr. Shekhar is a professor and the head of the Department of Family and Generations, and also heads the Center for Aging Studies at the International Institute for Population Sciences, IIPS, deemed to be university located in Mumbai. Sir is trained in demography and sociology. His areas of research interests include social demography, gender issues, population aging, welfare programs. He is a principal investigator of longitudinal aging studies in India, LASI, and the study on global aging and adult health, SAGE India. Dr. Shekhar was Fulbright Nehru Senior Research Fellow 2016-17 and at the Cornell University, USA, and also was a visiting fellow at the Wellcome Trust Center, UCL London 2003, Maison des Sciences La Home Paris 2004, Lund University, Sweden 2005, Oxford University, UK in 2009. He has authored and edited 10 books and has over 100 research articles in national and international journals. He was a consultant with Government of India, UNFPA, UNICEF, PHFI, Population Council, and many other organizations. Today, Dr. Shekhar will deliver his talk on dual burden of nutrition among elderly in India, evidences from LASI. I welcome you, sir, to deliver your speech.
Okay, thank you. Let me share my PPT. Is it visible? The PowerPoint is visible?
Yes, sir.
Okay. Thank you, Paramita, for a very generous introduction. And let me also thank the Director of NIN and Dr. Subbarao for inviting me for this webinar talking on this occasion of the World Food Day. Today, I am going to discuss with you issues related to nutritional status and food security of elderly population in India. As Professor Uday Kumar in his opening remarks mentioned that elderly is one of the most vulnerable segments where we had very little information available about their nutritional status and food security. So we have initiated a major survey called the Longitudinal Aging Study in India, popularly known as LASI, in order to understand the social, economic, and health dimensions of India's growing elderly population. So I think before I present before you some of the important findings related to the food security issues, as well as the nutrition, both undernutrition, underweight, as well as obesity among the elderly and the anemia levels. Let me give you a brief idea about the longitudinal aging study that will be very useful for those who are not aware about this major national data set. Now, LASI is sponsored by the Ministry of Health and Family Welfare, Government of India, also supported by the National Institute of Aging from the USA. At the International Institute for Population Sciences, IIPS, we are the nodal institution for implementing the LASI. We also collaborate with many national and international institutions in this process. The regional geriatric centers under the ministry located in 18 different cities, ICMR Nari Institute at Pune for testing our blood samples, and our international collaborators are Harvard School of Public Health and University of Southern California. Now, what are the important goals of LASI? LASI is to provide credible scientific data on burden of disease, functional health, healthcare, and social and economic well-being of older adults. So it provides internationally comparable research design and tools, adopting cutting-edge scientific methods to provide a foundation for credible and acceptable data for national policy and long-term scientific research. When we talk about children's health, women's health, we have very well-known surveys like National Family Health Survey and many other surveys. But when we talk about the elderly, we don't have a regular survey, that also in a longitudinal nature, to track the social, economic, and health changes happening to the rapidly growing elderly population. You know that 2011 census showed that we are around 100 million elderly. That is a 60 plus population in our country. But within the next 25 to 30 years, by 2050, it is projected that India will have 320 million elderly population in our country. So the challenge is going to be too much for the Indian society, the households and government to provide the basic social security and health care for this elderly population. So LASI will also provide the scientific data for strengthening the national program for health care of elderly. It will also support the necessary data for social security programs of Government of India, including the old age pension implemented by state and national government. So it will help us to develop a comprehensive national health policy framework for older persons and expanding the healthcare and social security programs to cover older adults and elderly persons in our country. So the major objectives of LASI are basically dealing with 4 domains. One is on health. It is the disease burden as well as risk factors. It is not only the self-reported health condition, but also measured using a wide range of biomarkers in our survey. Healthcare and health financing. Then at the social front, we have a lot of information about family, living arrangements, social network, social welfare programs, caregiving, elder abuse, and many. And on the economic side, we have data on the income, consumption, wealth, expenditure, health insurance coverage, out-of-pocket health expenditure, many other dimensions. We have collected the information. So regarding the health, we provide the estimates for the prevalence of the communicable and non-communicable diseases for all the population aged 45 and above, and also self-reported and measured health conditions on the total burden of diseases and particular focus on NCD and other associated risk factors, and also to understand the risk factors and social determinants of communicable and non-communicable diseases, including the economic and environmental factors, and to generally to study the demography of aging transition happening in our country, including the causes of death, life expectancy, and other things. We also have the information on healthcare utilization, disease pattern, the type of healthcare providers, household health expenditure, medical cost on treatment and healthcare financing, health insurance coverage, and quality of care. So in our health section, we have the data collected on various morbidity conditions, chronic diseases, and other conditions on endemic diseases. On mental health, we have collected a lot of information, including the cognition and probable symptoms of depression, functional health, ADL, IADL, and mobility and assistive devices required, healthcare utilization, and outpatient and inpatient visit, health behaviors of elderly, including smoking, alcohol consumption, physical activities, food insecurity, and many other issues. Now, as I said earlier, it is not only the self-reported information, we have also conducted a wide range of biomarkers through direct examinations. So we have functional health measurements like blood pressure and pulse rate, lung function test through spirometry, vision test. We have a set of anthropometric measurements. I will be presenting you some of the findings from this: height, weight, waist, and hip circumferences. We also have the blood samples collected, the dried blood spots, and based on that, we conduct the test C-reactive protein, CRP, HbA1c, and hemoglobin, and also performance-based test on grip strength, timed walk, and balance test. So it is a comprehensive survey covering both health, economic, and social dimensions of aging in India, with a comprehensive set of biomarkers using the latest technology of CAPI, the computer-assisted personal interviewing, where the data is directly fed into the laptops and transferred to the head to Mumbai, wherever the survey is happening, same day we are getting the data in our server in Mumbai, and all the latest IoT-based technology, including GPS and barcode technology. So broadly, the research design, it provides national estimates as well as state level estimates for all the states and union territories in India. So our study population is all the persons from the selected households aged 45 and above, and their spouses irrespective of ages. Okay, so we have around, in a wave one was carried out in 2017 and 18. We covered around 73,396 individuals aged 45 and above. Out of that, 32,000 are elderly respondents. So what I am going to present you, some of the findings are based on this national survey of 32,000 elderly respondents covering all the states and union territories in India. The idea is a longitudinal study. This study will continue for 25 years with regular intervals. The first wave was carried out in 2017 and 18, and we are in the process of launching the second wave. The survey will be initiated in 2023 and it will be completed by 24. And after that, every 4 years. So we are really able to track the social, economic, and health changes happening to the elderly population in our country. Now, LASI uses 3 schedules. One is the household schedule, one is the individual schedules, and one is the community schedule. Community schedule, suppose the survey is done in a particular village, we also canvass a village schedule where we get all the infrastructure, information, facilities available in that village, like where the health facility is located, how far it is located, educational facilities, what are the welfare programs available in the village, all that. So we have 3 schedules, unlike in most of the surveys where they use only household and individual schedules. And the most important part of LASI is that LASI is designed and introduced in synchronizing with the similar studies happening around 41 countries around the world. The study methodology, the questions, protocols are almost similar. So that will help us to have not only compare the situation within the states in India, but across countries and across cultures. And so with the LASI, India is also entering to an elite club of health and retirement studies across the world that is happening in around 41 countries. So now let me come to some of the important findings that is relevant to your theme today on the nutritional status of elderly. We have information about people reporting the self-reported diagnosed anemia. The question was, have you been diagnosed with anemia by a health professional during the last 2 years? This question was asked. We also have, using the blood sample, DBS, testing at the ICMR Nari at Pune, we also have really the measured anemia, actual anemia, which is much higher than the self-reported one. Then we have the anthropometric measurements and also a lot of questions on food security. So due to shortage of time, I will be giving some of the important findings from on all these 4 aspects coming from the LASI survey and the LASI data. Now, this is the self-reported diagnosed anemia during the past 2 years. So there was a question was asked to the respondents. In the past 2 years, have you had anemia? If yes, was this disease treated by a health professional? Are you undergoing treatment for that? So as you can see, among the men elderly, the self-reported anemia is around 3%. Women, it is almost double, 6%. And you can see the differentials across religious, caste, educational, and economic categories. You can see big difference. So self-reported prevalence of diagnosed anemia is higher among elderly with no schooling or less school education compared to those who are having at least 10 years of schooling. It is also in a way indicate the economic status as well. And it is also quite high in the rural areas compared to the urban areas. Now the question was, did you undergo any treatment or any health professional are treating you for this? So we can see around 80% of the male respondents said yes, but among the women respondents, it is 85. As expected, it is much less compared to the urban area, less in rural areas. So almost 84% of them have diagnosed anemia as undergoing some form of treatment by a health professional in some hospital, either in government or private, or some treatment they are getting. And you can also see the variations across the educational groups, as well as the monthly per capita expenditure. This is a proxy for the economic status of the household, because the income data is not that reliable. So we go by certain other measures like this. As expected, the treatment is much higher among the richest or the wealthiest 20% of the respondents or the households. Now, this is the measured prevalence of anemia based on our own testing. So the overall prevalence is much higher. It is around 33% among men and around 36% among women, any form of anemia, and is much higher in rural area compared to urban area. If you look at the caste groups, the scheduled tribes are the worst affected. Around 45% of them are considered to be the anemic based on the test. And those who belong to the poorest economic strata in terms of economic criteria and the wealth quintiles and all other things, which is much, much higher among them compared to the other groups. Now, we also have the data, as I said, this provides estimates for national as well as the state level. So this is the prevalence of measured anemia at the national level, around 30%. And you can see the big difference across the states considerably. From the various states, the prevalence level is varies considerably. Now, this is an interesting table graph here. You can see the percent distribution of elderly with their underweight, overweight, and obesity, normal conditions. So what we see here is more than a quarter of elderly, that is around 27% of them are underweight, and a fifth of elderly are overweight or obese, either of them. So indicating we are having a dual burden of undernutrition as well as overnutrition among elderly. It is not only the undernutrition. The undernutrition, underweight is around 27%, and whereas the overweight and obesity constitute around 22%. So you can see the differences among male and female respondents. The overweight and obesity is much higher among the female respondents, and also it is much higher in the urban areas. So there are considerable variations based on that. Now, this is the state level figures for the undernutrition, underweight, as well as overweight and obesity at the national level and across various states and union territories. Now, this is a measured prevalence of high-risk waist circumferences as well as high-risk waist-hip ratio. So what it shows that the prevalence of high-risk waist circumferences is much higher for elderly women. It is around 37% compared to the men, it is only 9%. And the prevalence of high-risk waist-to-hip ratio, which is much higher in urban area, 83% compared to the rural areas, which is 72%. So there are big variations across the groups. Now, coming to the food security, in last year's survey, we asked a set of questions to all our respondents. And these are some of the questions. Did you ever reduce the size of your meals or skip meals because there was not enough food at household in the past 12 months? And the second question was, were you hungry but did not eat because there was not enough food at household in the past 12 months, anytime in the past 12 months? And did you ever not eat for a whole day because Dr. Das was making earlier a presentation, the children, street children not having a food, at least one food in a day. And we also had a question, did you ever not eat for a whole day because there was not enough food at household in the past 12 months? Not because of health reason, because of lack of availability of food. So these are the three important questions we canvassed. And you can see the results here. So the food security related information as defined by Food and Nutrition Technical Advisory Committee group was collected on household food non-availability over a period of 12 months prior to the survey, or last 1 year before the survey. So respondents were asked these questions. So these are the percentage of elderly who experience food insufficiency by residents. Of course, as expected, it is much higher in the rural areas, almost double compared to the urban area in all the three categories. And among the education, if you take the education also, those who are having no education or illiterate, as well as those who have less than 5 years of school education, they are the worst sufferers in this case. Now, percentage of elderly who experience food insufficiency at household level by economic status, or what we have used is monthly per capita consumption expenditure quintile. So you can see the poorest quintile is much higher compared to the better, the wealthiest or richest quintile in that group. There are considerable variation on all the three categories. Did not eat for a whole day. You can also see the big difference there. Now, this is a question that information from the same questions. Have you experienced severe constraints in food availability? Severe constraints mean those who said yes to all the three questions. The three questions were reduced the size of the meal, or hungry but did not eat, or did not eat for whole day. So the severe constraints in availability of food means in the past 12 months, household members had to reduce the size of the meals, were hungry but did not have enough food, or did not have food for a full day because food was not available. So all these three put together, you can see at the national level around 8.6% of elderly, but states like Madhya Pradesh and Jharkhand, it is more than 10%, around 17% in Madhya Pradesh. So these are some of the preliminary or basic findings emerging out of the LASI survey. We have the more information available. We can do more analysis based on various other determinants, economic factors, social factors, living arrangements, family support mechanisms, as well as the health conditions as well. Since those who are interested to look at this report, the India report is available on our website. And we also produce the fact sheets for all the states and union territories. So if you want to know the status of elderly in Andhra Pradesh or Telangana, you can look at the fact sheet, which will give you an immediate reference to some of the basic indicators, around 197 indicators about the elderly. And the report gives you much more than that. And the LASI data is available in public domain. Those research scholars, those who are PhD scholars, those who are interested to work on this data set to understand the nutrition, health, living conditions, economic conditions of elderly. The data is available free of cost. You have to send a request in the data request form, which is available on our website, and you will get the data set within 3 to 4 working days. And if you have any more questions related to LASI, please write to us. We will be most happy to provide you the information. So thank you very much for a patient hearing. I am most happy to answer any of your queries or comments. Thank you.
Thank you, sir, for that very precise, lucid presentation and sticking to the timeline. That's excellent. And then we have 2 quick questions on the chat box. One was asking about, both are from one of our colleagues, Dr. Meshram. He says, what was the method used for hemoglobin estimation, and after how many days of DBS collection test was done, how the samples were transported. It's a linked questions.
Yeah. As far as the DBS question is concerned, of course, the DBS were collected in 2017 and 18 when the survey was carried out. It took more than 2 years to complete survey in all the states. In some of the states, it got delayed. And the DBS, within 5 days, they have to transfer the DBS from the field to the ICMR lab, NARI lab at Pune. It was stored at -20 degrees Celsius. And once the survey was completed, we carried out the test. And that is about it. It is usually followed in most of the other surveys like the National Family Health Survey. More or less, we collected the 5 drops of blood on a filter paper, dried blood spots. We are not using the venous blood. It is a DBS samples which were sent and stored there and tested there. And we also kept it there for a long time in case we want to do further testing in future years or something else, some or other problems, some or other issues, depending upon the requirements and availability of funds. So that will be stored for many more years, at least for next 5 years at the ICMR NARI lab in their freezer rooms. So there was a question about why the food security among the
Rich.
Higher among the rich. It's a good question. Now, one is that food insecurity is much higher among the poor, I can see. But those who went, it is, of course, it's a natural question. Those who are economically better off, why they are showing 2 to 3% of the food insecurity. There may be many reasons. You have to keep in mind that we are talking about the elderly, and good number of the elderly may be living alone. For example, in a state like Tamil Nadu, we found that 15% of elderly are living alone. It's a one member household, no other family member living with them. In Kerala also, in some of the number is quite high. So that may be the one reason for them not to get, or they are not able to prepare the food or whatever the type of food they want, they are not able to get it. And this is all household population. We have not covered the institutional population. That means those who are living in the care homes and old age homes and all the things. So that may be one reason for this thing. But by and large, the survey very clearly showed that it is the poorest. It is the poorest. It is reflected in many other indicators, like in rural area, it's higher. Those who are illiterate, it is higher. And among the scheduled tribes, it is much, much higher, most of these indicators. So the scenario is something like that. Yeah.
Sir, did you also assess the depression levels, mental health and things like that, and their association with food and nutrition insecurity?
We have done some analysis, so I am not presented here about that. We have a question about the depression and probable major depression. According to our survey and analysis, we have used 2 scales to measure that. According to our analysis, around 8% of elderly are having major depression, according to our survey, based on one scale. That is a very serious condition. But of course, this depression can be for many reasons. One is that, of course, as you said, hunger, lack of food and other things, lack of treatment, or elder abuse and elder ill treatment happening within the household, or many other factors, life satisfaction, health conditions. Many of them have chronic health conditions. We found that the 14% of them are severely diabetic, and the cardiovascular disease is among around 34%, including hypertension, many other things. So the more you likely to live, the life expectancy is increasing. but it's also a fact that large number of our elderly respondents or senior citizens are also living with severe chronic health conditions, which will also have an implication for their mental health as well as the depression levels among them.
Yes, sir. Thank you. And there is a continuing question on that also about the estimation of if the hemoglobin estimation was done 15 days after 15 days of collection. I think you said 5 days, no, sir, not 15 days, right?
No, within in every location, our survey team will spend 5 days.
Okay.
5 days, they will complete the survey, individual interviews, household interviews, and the blood sample collection. Then they have to send that through Blue Dot courier to ICMR Nari. It should reach there within another 8 days. It should reach. That is the way in a specially packed format. That is the way. So survey in one location, the survey takes around 5 days. Once that survey in a location, particular village is completed, the blood samples were couriered to the ICMR lab.
Okay, sir. I think, thank you very much. There is yet another question that's about food security. FAO usually uses 8 questions, and why did you use only 3 questions? I mean, is it a validated measure kind of a thing?
Yeah. It is nice. It's a good question. Basically, we had actually 4 questions actually to tell you. I presented you only 3 questions. We canvassed 4 questions. One question was, which I have not mentioned here, is that in the past 12 months, did you, the question was, in the past 12 months, did you eat enough food of your choice? Yeah. We have that information as well. But in calculating the presentation, I have not taken that question. The other 3 questions were included. Now, of course, there are FAO's panel and many other nutrition surveys use a large number of questions to measure. But you see, nutrition is one aspect among our larger basket of elderly welfare. So social, health, economic, mental health, welfare, so many questions. So we have to cut short somewhere. So we felt that these are the 4 important questions we need to canvass, and accordingly we have done it. But we are also reviewing our questionnaire and experience when we are going for the wave 2 survey next year. We are also thinking of adding more questions, including a question or a module on COVID. What was the impact of COVID on elderly? We are going to ask a question. That survey will be carried out next year. Okay. Thank you very much.
Thank you, sir. There is another question about tools used for assessment of depression. I think that's outside the purview of this seminar. I mean, if you have time, sir, you could answer it online for us.
Yeah, actually, in a one sentence, I think the more detailed information is available on our report, which you can download from our website. We used 2 scales, CIDF, SF short form, and CEST. There are 2 scales used in our survey, and all the details are available in our report. So I request you to go through the report, download the report, and further, if you have any questions, please write to us. We will clarify.
Thank you, sir. Thank you for that presentation. Now we move on to the next presentation, which takes a segue from the presentation that Dr. Shekhar had made. And my colleague and head of Biochemistry Division, Scientist G, Dr. Bhanu Prakash Reddy, will make the presentation. But before that, may I request my colleague, Ms. Reshma, to introduce Dr. Bhanu Prakash Reddy.
Hello, good afternoon to everybody. I'm so happy to introduce Dr. Bhanu sir over here. Dr. G. Bhanu Prakash Reddy is a Scientist G at ICMR National Institute of Nutrition and heading the Biochemistry Department. His research is focused on molecular nutrition of chronic disorders, that is NCDs, underlying basis of the disease, evaluation of nutritional status, role of micronutrient on molecular processes involved in NCDs, protective effect of functional foods. He has published over 220 research papers in scientific journals, and 25 students have obtained PhD degree under his guidance. He is a recipient of ICMR Basanti Devi Award, Scopus India Young Scientist Award, RPB International Scholars Award, ICMR Dr. V.N. Patwardhan Prize, and Nutrition Society of India Young Scientist Award. He is also a Fellow of National Academy of Medical Sciences, Fellow of the National Academy of Sciences India, and he is a member of FSSAI Scientific Panel and many other scientific committees. May I please welcome Dr. G. Bhanu Prakash Reddy to present his topic on nutritional requirement, why elderly cannot be left behind. Over to you, sir.
Thank you, Reshma, for that kind introduction. This audio is fine? Okay, let me share my presentation. Okay. Just also change my video panel, which is okay. At the outset, let me thank my director and also today's Director in charge, Dr. Uday Kumar, and the coordinator of this webinar, and my good friend, Dr. Subbarao, for asking me to present something that we have a little bit on this, but we have bigger plans on that. Having said that, I also want to make a couple of comments or remarks before Dr. Professor Shekhar leaves, in case if he is planning to leave. Actually, his presentation made my job much easier. And secondly, I think at the end of my presentation, sir, I think we may have to have a dialogue and to see that where can we head together. I think there seems to be a lot of things that we can achieve together. So maybe we will discuss later. To begin with my presentation, as the theme is that leave no one behind. And aptly, I think today's webinar focuses on two unique categories of the population, that is street children and elderly. My presentation is on a specific aspect of nutrient requirements and why elderly cannot be left behind. Let me also say that the second part of the title is the idea of my colleague Subbarao, who is also a co-author of the paper that I am going to tell you at the end of it. Thank you, Subba. Well, I think this part is covered by Professor Shekhar, and this is the demography of the elderly. I will not elaborate on that, but aging is a natural and progressive deterioration in many biological functions, along with the natural age-related changes. Of course, the point is that it is a multifaceted etiology. And I also want to, for the benefit of the audience, particularly for the students, elderly, old age, senior citizens, these are all synonyms or kind of terminology. But how do you define is with a subjective aspect, like typically or technically elderly or old age, it can be defined that those who surpass their average life expectancy. But this life expectancy can vary among the geographies, among the populations. Anyway, having said that, but right now we are going to go with either 60 and above or 65 and above because different agencies use different cutoffs. Let me also give some data on that. Number of persons 60 and above globally was 1 billion in year 2019, and this is expected to be double by 2050, something what Professor Shekhar already alluded to it. According to UN, which 6 to 65 years cutoff, and the elderly number was 700 million in 2019, and again it is going to be almost double by the year 2050. And then as far as India is concerned, Indian population has tripled in the last 50 years, but at the same time, the elderly population has increased almost fourfold. And this increase can be seen mostly in the eastern or southeastern countries, Asian countries, rather than other countries. Just to give me 1 second, I'll select my pointer option here so that it is better. Yeah. So you can see that the increase will be much more in South Asian countries. As far as the Indian scenario is concerned, again, in 2019, the number of aged population, again, Professor Shekhar touched upon this. We had about 90 million people above 60, and this is going to be more than 200 million by the year 2050. And as you see, with the time, the life expectancy also keeps increasing. Right now, it is somewhere around 70 point something. This figure is 2020 figure, but I think it has slightly changed by now. And what is important is that the increased longevity of the elderly people is associated with the burden of several non-communicable age-related diseases, which I'm going to show in the next slide, which is again touched upon by Professor Shekhar. Like, there are many age-related disorders. I will not list each one of them, but categorically like neurological, cardiovascular, different types of cancers, and many metabolic diseases. But the point here is that all these age-related diseases happen with a process called accelerated aging. The reason I say accelerated aging, the rate of aging can vary among the individuals. So what are the processes that govern the aging or rate of aging is like some of the physiological and biological processes listed here: inflammation, oxidative stress, telomere length, DNA damaging, autophagy, immunosenescence. The point here is that all these things are somewhere or the other controlled or connected to the nutrition. That's where I think our presentation is very relevant. Now, as we have been saying, that chronological age of an individual does not really represent the biological age. So this is the crux of the whole thing, that how we manage the elderly, whether nutrition or for that matter many other aspects associated with aging. Therefore, we need to have biomarkers of aging, or whatever the phenotype that can really tell us the aging. One of the things that can be used to really pick up the biological aging is priority. There are many biomarkers, but all of them are non-specific, and still many studies are trying to identify the biomarker specific for aging. One of them is priority. The priority is a phenotype characterized by reduced strength, endurance, and has high risk towards the various events such as falls, disability, hospitalization, mortality. In a small pilot study very recently, we have shown that in elderly above 60, the prevalence of priority is about 25%. Now we are extending this study, as well as we are trying to identify some specific biomarkers. This is where I'm saying that maybe if we work with Professor Shekhar and IIPS, we can actually do a good job. Having said that, let me go to the point that what I want to say is that, as I mentioned, aging is a multifactorial etiology. There are many factors that are associated with aging, be it physiological. I will elaborate on physiological, and it could be social aspect, economic, metabolic changes, immunological, and of course molecular and cellular aspects. But the important point is that all of them are somewhere or the other again connected to nutrition, because nutrition is the one that influences to some great extent aging process. The reason is that there are some studies, or good number of studies, which indicate that, including the studies from NIL, our colleagues, Dr. Arlappa and others, who report that the suboptimal nutritional status, particularly in elderly, as far as the micronutrients is concerned, and that could be a contributing factor to the prevalence and severity of many age-related non-communicable diseases. And we all know that the connection between micronutrients, many age-related non-communicable diseases that are listed here, the nutrients that are connected with it, whether it is zinc, vitamin C, quite a few B vitamins, vitamin D, vitamin C, are linked to those the NCDs that I have listed here. And with respect to priority, it's the protein, UFA, and some B vitamins like B6, B12, etc. are important for the prevention of priority. We have some preliminary data with respect to these vitamin deficiencies. Just for the comparison sake, I've picked up the data from our own studies to show that what is the difference between below 60 and above 60. You can see that the people above 60 have higher prevalence of some of the vitamin deficiencies like B2, B6, and vitamin D and folate. So this, of course, as a part of our other study, but I just segregated the data for the purpose of today's presentation. And also we have the deficiency of, this data is the blood data, not the dietary intake. The deficiency of quite a few minerals compared to below 60, above 60, the levels are much lower. intriguingly, for some reason or the other, except the zinc is slightly higher, but we have no idea why that is this particular study. And this again, is supported by the lower intake of many food groups. I'm not going to list them here. All the food intake of these food groups are much lower in people of age above 60. And particularly here, I have segregated the data with the prial and non-prial. If you see the prial people have lower intake of the food groups. And this, if you translate it to their adequacy of the nutrients or inadequacy of the nutrients, you could see that there's an inadequacy of many nutrients in the people who are above 60. So then this is again corroborated by the presentation of Mr. Shekhar. I picked up some of these things. I don't repeat them, but maybe my data that what I gone through the last year report could be slightly older than what Professor Shekhar has presented. So according to the LASI, about 30% of the elders are underweight and about 20% of elderly are overweight and obese. That means both the extremes are there. So this also tells us that there cannot be a single package or universal mechanism to deal with this. You may have to have a multi-pronged approach to handle this kind of situation. That is very important. Otherwise, we can always get confused with that what kind of intervention should be taken up. I will not again go back, as he said, in the rural area, the situation is slightly different compared to the urban area. And in contrast, actually, the prevalence rates of overweight and obesity are more common among elderly in urban area, and that is to some extent expected. Having said this, what is that now we have to do as far as they're improving their nutrition? There are some actually needs, but that the needs are actually faced with some challenges. Let me tell you what are the needs and what are the challenges. To ensure the quality of life, especially in relation to age-related changes and age-associated ailments among elderly, nutrition is the most determinant of health among elderly. So some of these changes could be like whatever the changes associated with age I mentioned, some of these changes could be minimized, mitigated, or prevented through appropriate dietary guidelines and nutrient recommendations. For such nutrient recommendations, one has like how do you develop the nutrient recommendations to be developed and disseminated to context-specific nutritional requirements. That is where actually I'm saying the need and the challenge. You cannot generalize the requirements that NIN has already made for the children and adults. I'm going to elaborate on that point a little later. As I say, the existing nutritional requirements, mainly for Indian children and adults, are derived using a factorial approach and may not be fully relevant. Yes, I cannot say that they are not at all relevant, but they may not be fully relevant to the elderly for the reason that I mentioned, and I'm also going to elaborate some reasons how they cannot be relevant to elderly. And this problem is further compounded by the depth of information on dietary intake, nutritional status, and physiology of the elderly in India. I'll elaborate on what actually this physiology and Professor Shekhar though mentioned some aspects of anemia and other aspects, but there is no data on dietary intake, there is no data on nutritional status in elderly in India. That is where we are now. Just to say that how do we establish the nutrient requirements? As I mentioned, nutrient requirement is something that is the minimum amount of nutrient necessary for maintaining the normal physiological functions of healthy body. So this intake should meet the requirement. That is how actually you keep the healthy people healthy. So basically, the requirements are for apparently healthy people. I mean, nutrient requirements are derived based on the information for the healthy people. So for that, actually, we should know the daily requirements. Then only you can say that what is the meeting, how do you meet the requirement. So this requires accurate measurements experimentally. But many times that is not possible, if it's not impossible, but it is little cumbersome. And again, it varies in physiological groups depending upon the growth period or pregnancy or infection or lactation, etc., etc. Therefore, doing an experimental kind of exercise is a very cumbersome. But it is possible to define requirements to prevent the risk of inadequate intakes in an individual or in a population. That's how they they compute that what is the average intake, and then what is the they pick up the filter out the people with a healthy status, and then they come up the dietary reference intakes. And using many other factors, very recently NIN has released revised the nutrient requirements and released in 2020. But as I again say that this is for mainly for children and adult population. which sometimes is not helpful for the elderly for some of the nutrients. Let me tell you why is that. Why we cannot extrapolate adult requirements to geriatric population? For various reasons. If you take muscle mass and strength with the age, as you see, you grow old, the muscle mass trajectory, somewhere between 30 to 40, the muscle mass and muscle strength keeps coming down. But this is not uniform. Okay, there's a minimum loss for a good number of people, and there's a maximum loss. There's a minimum loss. How do you fill this gap? And one has to identify what are the factors that govern this muscle loss. And most importantly, the muscle, that is lean body mass, is the very, very critical factor for determining the nutrient requirements. At the same time, if you see fat-free mass and cell mass, again, fat mass is you see not that much of decrease compared to the muscle mass. This is the one that is going to determine, as I mentioned, with aging, lean mass decreases, fat mass, proportionally fat mass increases as a result of metabolic rate decreases, and accordingly energy requirements come down. Particularly protein requirement is required to be a little higher, and micronutrients. So all in all, the direct extrapolation of adult requirements is not a good idea for the elderly. And also clubbed with this kind of physiological data, we have some information how the nutrient requirements change and require a different approach during age. Let me tell you some of the reported studies or available evidence. With aging, as I mentioned, energy requirements gradually decrease between the ages between 30 and 75 years because of the changes in lean body mass and the basal metabolic rate also, because basal metabolic rate comes down. For one simple reason, there could be many reasons, there is a reduction in physical activity. I think last year study, 2010 study, I do not know about the recent reports, as reported in 4 states, almost 70% of the elderly have zero physical activity. So that is where actually this information is very much essential for deriving the nutrient requirement. At the same time, protein requirements increase with age. Generally, it is 1 gram per kg body weight to meet the calories of about 12 to 15. But to maintain your muscle mass and to prevent sarcopenia. But at the same time, we also have to take care about the carbohydrates, particularly adequate carbohydrates. When I say adequate carbohydrates, it should be particularly complex carbohydrates that need to be provided to protect the protein being used as the energy source. Otherwise, if you do not provide enough carbohydrates, your protein will be utilized. So that can lead to the protein deficiency. And dietary fat anyway has to be given to meet the requirement between 25 to 30. Particularly people who are above 70, if they have obesity or some other metabolic diseases, the calories cannot be more than 30 from fats. But if they are okay, then the calories can be as high as up to 35%. And most importantly, it should be omega-3 rich than the omega-6 rich. And there are other physiological aspects like constipation is one of the main problem, chronic problem in many older adults. Therefore, adequate fiber together with the adequate fluid. The reason we say this is that as I mentioned in the previous slide, fat mass, proportionally fat mass increases, and relatively fat holds lesser water compared to the muscle. Therefore, they are more prone for dehydration. That is where I think adequate fluid and adequate fiber is required for elderly. But how much is required? Again, we have to have the data. What is the loss of muscle mass and what is the increase in fat mass in our own context? Like this, there are many contexts. I will quickly go through that. Carotenoids are very much required to reduce many age-related diseases, particularly macular degeneration. And we all know vitamin deficiency is documented to be a worldwide epidemic, and especially in the elderly, and more so that as a result of decreased sunlight, particularly the institutionalized older adults, they do not get exposed to the sunlight. And there is also a decreased intrinsic synthesis of vitamin D metabolites and increased the parathyroid hormone, as well as age-related changes in body composition, which I just mentioned, clubbed with lower dietary intakes and increased vitamin D receptor. This is biology. Further, kidney's ability to convert 25 vitamin D into 125 is reduced, and also the absorption of vitamin D from the gut is decreased. Lower vitamin D levels are related with risk of fractures, cause, all that is known. So this kind of biology and information is available, but at the same time we need to generate other information so that we can put together and come to a conclusion for deriving the requirement specifically. In addition to vitamin D, there are again poor thiamine status, B6, folate, etc., clubbed with neurodegenerative diseases is reported. Therefore, these requirements could be slightly different. And some of these B vitamins, particularly pyridoxamine, is known to prevent some of the age-related protein modification. And we all know the importance of B12 and B2 in the context of homocysteine metabolism, because homocysteine is a risk factor for many age-related diseases, including vascular diseases. So that's where I think the question comes in: how do we derive this? And also the malabsorption of foodbound aspects with respect to B12 absorption. I will not elaborate on that. There's much information is available, and the role of zinc in immune response, and particularly requirements of iron in women decreases slightly after menopause. Therefore, I think this aspect needs to be taken into consideration. And as you see, from Professor Shekhar's data, the anemia in elderly is much less compared to the what we talk about the vulnerable groups, either children or women. So this is one issue that one has to take. You cannot just give the same iron to the elderly people, but again that needs to be kept in mind, that whether they have any other ailments, whether they have any problem with anemia. And obviously requirements for calcium increases with age, because there is a decrease in intestinal absorption of calcium, and as I mentioned about vitamin D malabsorption and malfunctioning of vitamin D metabolism, decreased circulation of gonadal hormone, many other things. So just to say that keeping this still, NIN has made some changes in our nutrient requirements to elderly. This is not a comprehensive recommendation, but for a few one. Let's say, as I mentioned, vitamin D recommendation, as against 600, here it is 800 for elderly, and whereas the calcium recommendation is as against 1000 mg, it is 1200. But we do not have such. Again, this is based on some postulates and assumptions. It's not based on the robust evidence. Nevertheless, there is some recommendation. But again, we need to have. At the same time, there is the requirement for iron for women particularly has been changed compared to the adults. I think in adults it is 29 or something like that. So also niacin requirement is slightly decreased, taking some assumptions. What I am trying to say that these some limited recommendations are based on some assumptions, but we need to have comprehensive data for all the nutrients that we have to derive the requirements. So this is where I am saying in the Indian context, available requirements are specified for average healthy adults, which are primarily derived by factorial approach of considering the nutrient losses adjusted for body weight, BMR, physical activity, total energy expenditure, total nitrogen balance, and bioavailability, etc., etc. But these do not factor in for the above mentioned age-related changes, and hence may not be adequately poised to meet the challenges for the aged individuals. This is where I am again saying that. But at the same time, there are some international agencies such as IOM. Now, IOM is called, I think, National Academy of Medicine. IOM has made some recommendations for elderly. Even these requirements cannot be extrapolated to the requirements of elderly in India for various reasons, that our context is different. But their recommendations are not above 60 and not for above 65, simply for above 50 years, which actually is not helpful for us. Even if you see the recommendations for above 50 by IOM is, let's say for above 50, the recommendation for vitamin D is 800, which is actually more than our adults. Okay, so this is not going to help us. What I am trying to say that the recommendations that IOM gives is not going to be useful for us. Of course, even EFSA has got some recommendations, something like what I mentioned here, which is not again useful to our context. So then what is the way forward? It is necessary to compile and collect evidence on age-dependent body composition changes among the elderly in India to define the reference body weights. I repeat this because reference body weight is most important along with other body composition parameters, which would serve as the first step in defining the nutrient requirement. Simultaneously, data on nutrient balance and nutrient losses among elderly are important to aid in evolving robust estimates of nutrient requirements. And at the same time, systematic assessment of dietary intakes and their possible association with the quality of life among the elderly in India is the need of the hour. And it is also essential to assess comprehensive nutritional status of the older adults in terms of anthropometric indices, dietary patterns. It's good that LASI has this kind of data, but if it can be clubbed with the dietary patterns and subclinical status of micronutrients, then we have I think a good amount of information in the days to come, so that we can evolve some strategy. considering that elderly individuals are at an increased risk for hyperkalemia and hypo or hypernatremia, which results in adverse health effects, a careful consideration should also be given to electrolytes, which is many a times is not taken into account, particularly for elderly adults. It is very much essential. And as I already mentioned, micronutrient deficiencies are linked to various age-related disorders. In view of rampant micronutrient deficiencies in our context that are associated with low diet diversity, this is one aspect for us. Unlike the other countries, we are facing the problem with low diet diversity, which could be the major reason for micronutrient deficiencies. Special emphasis should be given on the relevant contextual factors for deriving dietary requirements of micronutrients for the elderly. Some micronutrients such as vitamin D cannot be met entirely from the diet. This is one factor one has to keep in mind, because this cannot be met from the diet actually. And as it is, elderly are faced with vitamin D deficiency. Therefore, for these kind of micronutrients, supplementation or consumption of fortified foods may serve as alternatives to meet the requirements, but this requires again robust evidence. So it may also be pertinent to harness the potential of some bioactive components, but I will not get into that today. And this should be complemented with an onus on the importance of healthy lifestyles and physical activity for better health outcomes. This will help translate the nutrient requirement recommendation into food-based dietary guidelines. Again, this is one important factor that we have to derive food-based dietary guidelines for the elderly at a national or regional level. There could be differences, regional differences. That is also important for us to keep in consideration. So the last slide is that what is required: continuous and concerted research programs, maintenance of long-term cohorts, developing appropriate biomarkers, monitoring food intakes, and assessing bioavailability of nutrients are all necessary to revisit the nutrient requirements from time to time, particularly for elderly. Finally, the process and plan for development of the nutrient requirements for the elderly should also include a wider translation and dissemination plan to benefit the target group. And in tune with the MyPlate for the day that ISMR-NIN has developed recently, in tune with the MyPlate for the day developed by ICMR, it would be appropriate to suggest MyPlate for the day for elderly once we have such information to serve this could be a ready reckoner for the elderly group. This is what I'm saying, that this is for elderly and this is for the adults now. We have to develop a MyPlate for the elderly. So with this, I stop my presentation here. And a good part of this presentation is covered in a status paper called Nutritional Requirements for the Elderly in India. And this is in press. Maybe in the next few weeks, it should be in the issue. And all these, my colleagues, including Dr. Subbarao, are a part, and my director are part of this exercise. Thank you very much.
Thank you, Dr. Bhanu Prakash, for that very quick and comprehensive presentation. I think the topic is very vast, but the take-home message that is that why we cannot simply extrapolate what is suggested for the adults to the elderly. The rationale has been brought out very well, and as you said, if we can collaborate with the IIPS, I think our job will be made much easier. That we had only diet data and physiology-related data, I think we can go a long way. There is a question, sir, for you. How to deal with such elderly people who have this preconceived notion that if they eat more, then they will get constipated or totally reject fats?
Can you repeat that, Subha?
How do we deal with the elderly people who have a preconceived notion that if they eat more, then they will get constipated, or they totally reject fats?
Okay. Well, I do not know if I'm qualified to say on this because I'm not a clinician. This is something physiology and some aspects of medical history needs here. What is the reason for rejection and what is the problem and the physiological problem? But we always suggest a frequent small meals. In other words, as long as they do not have any other issues. But the constipation could be a physiological issue. That's why we always say that fiber-rich food and the ones that can be easily digestible ones, like what we say, those can be easily assimilated. So these are the foods that one has to recommend. Okay. I think a dietitian is a better person than a biochemist like me to suggest something on this.
Yeah, Dr. Bhanu, I have a personal question. now that we don't have adequate data on dietary intakes of the elderly and other aspects related to them, would it be helpful to actually have a cohort of people who are just to be elderly, like you recruit them in 45 to 50 or 50 category, and then see how their dietary patterns have shifted from being an adult to an older population, and then would it be helpful to arrive at the nutrient requirements?
Absolutely, Dr. Subbarao. I think that is one of the points that we mentioned in the way forward, that we should have some cohorts, not only for the point that you mentioned, even to follow the trajectory of this body compositional changes.
Yes.
Because you cannot take body composition for some subjects now and after 20 years in another subjects. That may not be the right way to do it. But I think maintaining some cohorts are useful in many, many ways, including the point that you mentioned.
Thank you. There is another question. It says, as you mentioned, 1.5 liters fluid daily. Is it sufficient, as we recommend 2.5 to 3 liters daily? This is a question.
No, I think I mentioned in the presentation, it's not 1.5, maybe 2 and little more than 2 liters. 1.5 is a general recommendation, but I think for elderly it is 2 and 2.5. Well, I do not know. Sometimes recommending more also is not a good idea. I think we should not go to the other extreme. But I think 2 to 2.5 liters can vary between the individuals.
And one last question, Dr. Bhanu, why there was a specific emphasis in your slide on electrolytes?
Yeah. See, there is actually two issues. One is the hyperkalemia, and other one is hypo or hypernatremia. It may be due to various other physiological changes or metabolic changes. I think the practitioner can diagnose, but that is a common thing in elderly. Therefore, whether you need to know how do you come to a recommendation on electrolytes, this data is required. In an average population, what is the status? We do not know. On a case by case, they recommend sometimes give potassium, but we do not have such information in an average population, because recommendation is for average people. You don't take one particular case.
Thank you. I think I don't see any more questions, and we are well on time. Exactly, and I thank all the three speakers for their very insightful talks, but sticking to the timeline. I mean, by the way of summing up, I think it's a huge thing to sum up, because as the theme of the World Food Day celebrations itself says, leave no one behind. We could, there are several groups that are usually considered vulnerable, but there are several other groups which are vulnerable, but they are not usually considered. So this particular webinar was trying to cover those sections of the people who are vulnerable, but usually are not considered in national safety net programs and other things. In the initial presentation, Dr. Antaryami Das had given us new perspective about street children as to what drives them away from home. Could be food insecurity, which is a very, very, very illuminating thing for me personally. And also to understand that, there are more than 18 million street children with whatever data that we have. But I think it's, as he said, there is a need to actually document and then see how many of them are actually there, and then how their needs can be fulfilled despite the existence of many national programs. A large chunk of them are not covered because they do not know, because there is no demand for them. And food and nutrition security are only some of the problems, but they are very important problems which are often ignored. And Dr. Shekhar, as Bhanu had already said, had laid a good foundation for the next talk. And then we knew that there was LASI study all this while, but we did not know the depth of the study so far. And it is very interesting. He just scraped the surface about food security and nutrition security to match it to today's theme. But there is so much other data that we can, and as Dr. Bhanu Prakash was suggesting, it would be great if NIN can collaborate with them for at least the next round. And it will be also nicer to see in the next round if they can include institutionalized elderly population, because their points of view could be a little different. And coming to the last talk by Dr. Bhanu Prakash, he clearly told us why direct extrapolation of adult nutrient requirements to the elderly could be a little dangerous, especially in Indian context, and why the existing recommendations of IOM or EFSA cannot be. EFSA, of course, doesn't have all recommendations for all, but nevertheless, we cannot directly use them in the Indian context because of our specific requirements. But having said that, we do not have adequate data or information in Indian context to arrive at the requirements. I think this would be one of the priority areas for NIN in future. Thank you very much for all the three presenters for that very interesting webinar. And by way of vote of thanks, I would just like to thank our director for asking us to do something on the World Food Day and cover really the uncovered population, so that the topic, the theme for this year can be touched. And my profuse thanks to Dr. Uday Kumar for accepting to deliver deliver the inaugural address on behalf of the director, and he set the tone for today's talk with very pertinent points that he made in the inaugural address. And my special thanks to all the three speakers, Dr. Antaryami Das, Dr. Shekhar, and Dr. Bhanu Prakash Reddy, for accepting our invitation and delivering their very interesting and insightful talks. And I would be failing if I don't thank my team at Niche Division, who have done everything. The name is mine, but the rest is done by my team, especially my colleagues Raju Nayak, Bhaskar, Panda, Rishikesh Panda, Naresh, and the three wonderful ladies who have introduced the speakers today, and also all the groundwork related to creating the webinar and the links and other things was managed by the team. Thank you very much. And I thank the scientists, students, and also the PhD scholars, and many academy and other stakeholders who have joined from other parts of the country, and also who are seeing the webinar live on YouTube. For your information, the YouTube link still remains, and the webinar can be watched anytime by those who missed any part of the talks. And I will thank Anantan and also Mahesh of the General Club secretaries for giving it wide popularity, and also my thanks to the electrical division, especially for ensuring that there are no power outage and there is no Zoom disruption today. And thank you very much, and for everyone in the institute for supporting us so much. And this I am sure is available on YouTube, and you can probably go back to the presentations once again and then see if you have missed any part of this. And thank you very much. Thank you one and all. Stay safe, stay happy, and please ensure that in whatever we do in terms of nutrition research, we don't leave anyone behind. Thank you very much.
Thank you. Thank you, everyone.
Thank you, everyone.
Thank you. Bye.